No doubt some of you at least may be wondering where the title of this particular presentation comes from. You may have thought I got the historical reference wrong, that it was Occam's razor rather than Occam's laser. However, the point of the title is that in medicine today, a razor is much too brutal an instrument for the very fine-grained kinds of moral issues and moral judgments that have to be made with regard to what? With regard to the responsibilities of physicians to make more efficient choices with regard to the care that's provided to patients. The basic moral issue that I'm going to be addressing is this: how is it that a physician is supposed to be a loyal and uncompromised advocate of the best interests of his or her patient when it's the case that we have only limited resources, money, that we're willing to make available for purposes of providing health care, and there are enormous unmet health care needs in our society that ought to be met and that ought to have higher priority in terms of allocating health care dollars than some of the things that physicians are doing for their patients today. That was probably a pretty long-winded version of what that's supposed to be about. Okay, let's see if this works. Good. Okay. You know, you saw these figures before, so I don't have to go through them again. The projections out to 2019, 2020 are that we're going to be spending about $4.5 trillion on health care in the United States, about 20% of our gross domestic product. This is what's driving the emphasis on we have to find ways to control health care costs, and the focus of that effort is going to be on physicians, because ultimately 80% of all health care dollars are allocated by individual physicians at the bedside, deciding which patient needs to be in the hospital, which patient needs this drug, this diagnostic test, and so on. So that's the basic problem. Nice slide there. And the beginning of the problem that I'm talking about this morning comes from the American College of Physicians, and the quoted passage there where they write, "Physicians have a responsibility to practice effective and efficient health care and to use health care resources responsibly. Parsimonious care that utilizes the most efficient means to effectively diagnose a condition and treat a patient respects the need to use resources wisely and to help ensure that resources are equitably available." Now, that passage created a bit of a firestorm earlier this year when it was published in the Annals of Internal Medicine. And the word parsimonious is the word that got a lot of attention. So I want to, in some sense, locate that word for you in terms of a sort of moral vocabulary. And so this is the language that I'm going to ask you to have in mind for the rest of the presentation. We're going to use 6 P words here. On one end of the scale, we're going to have penurious, penny-pinching care. Okay? So nobody's going to be a strong advocate for that. In the middle of the scale, we're going to have parsimonious, prudent care. Okay? And that's what the American College of Physicians is advocating. And at the other end of the scale is promiscuous, profligate care. And the argument of many, and in particular, as we'll see in this book, Overdiagnosis by Gilbert Welch, who's a physician, a well-known physician, we'll find that his argument would be that at the present, what we are providing, at least to well-insured Americans, is something closer to the promiscuous, profligate care than to the parsimonious and prudent care. That when we have limited resources to meet unlimited health care needs, we really ought to be providing. Now, it would be, in fairness, in the American College of Physician Ethics Manual, where that first quotation came from, the passage that precedes that, and it's important to keep it in mind, goes as follows. The physician's first and primary duty is to the patient. Physicians must base their counsel on the interests of the individual patient, regardless of the insurance or medical care delivery setting. The authors add that no matter how physicians are reimbursed, physicians must not allow such considerations to affect their clinical judgment or patient counseling. So that's a very strong statement too. And it's because we've got these two demands that are both seen as moral demands on physicians in practicing medicine that we really need something like Occam's laser to address where we're going to draw the line, how we're going to distinguish between morally appropriate parsimonious care and morally inappropriate penny pinching or penurious care. Daniel Callahan writes, quote, physicians are never going to be comfortable denying what they believe to be beneficial care in the name of saving Medicare from insolvency. But then he asked, well, what's the alternative? Because by the end of 2019, Medicare will be at $1 trillion per year in the U.S. Right now we're at about $560, $570 billion. So Callahan goes on, then patients will be at the mercy of escalating copayments and deductibles, now the chosen method of rationing by Medicare and private insurers. Part of what could be referred to there, depending upon how the Ryan proposal ultimately gets construed. I mean, what he's talking about is we're going to provide, the Ryan proposal involves providing patients with a fixed sum. You can call it a voucher, or you can just say it's a fixed sum of money that Medicare patients can use to purchase either the Medicare as it currently is provided or some private insurance plan that's equal to Medicare. But that fixed sum, if it's reduced in order to save Medicare dollars, means that patients will be expected to pay a larger and larger portion. And so then, in effect, patients ration their own care, often thoughtlessly, mindlessly, without the level of understanding that physicians would have in making such choices. So we ask, which choice do you, as physicians, see as being morally preferable, all things considered? Are you willing to wield Occam's laser? If we had unlimited resources for meeting patient needs, then we wouldn't have to talk about physician obligations to provide parsimonious care. But medical needs are endless, and this, of course, is because of advancing medical technology, which in effect is constantly creating what we in effect identify as more and more in the way of medical needs. And so this is what generates the shrill demands from taxpayers and insurance premium payers to do something about controlling healthcare costs. So I've argued the need for healthcare rationing. I'm going to use that word too, because one of the claims I'll be making is that even though the authors of the ethics manual deliberately sort of avoided use of that rationing word and like to think of parsimonious care as not involving rationing, fact of the matter is there's going to be a huge overlap between what we would regard as parsimonious care and what can be correctly, from a moral and linguistic point of view, described as an instance of rationing. So what should be the role of physicians in addressing both the micro and macro rationing issues? And you can distinguish rationing decisions with regard to absolutely scarce resources, such as organs for transplantation or ICU beds, from fiscal resource rationing, which is mostly what we're actually going to talk about. The argument, and as I already mentioned, some are going to argue that there's this huge distinction between parsimonious care and rationing. I argue instead that there's a lot of overlap between those two categories. And then, as I mentioned, Gilbert Welch, in this book, this recent book of his, Overdiagnosed, Making People Sick in the Pursuit of Health, argues that all sorts of standards for being ill have been altered over the past 30 years, such as lowering total cholesterol levels, so that now, for example, with regard to cholesterol, he says when he started practicing medicine, he's an older physician, the cholesterol level at which he said, you got to do something to bring that down, was around 320. And then it went down to 280, and then 240, and 200. A lot of people are saying it ought to be at 180 for total cholesterol. And of course, I know you've got the formula for your LDL and HDL and so on, and other factors to take into account. But he does ask the question, if we're kind of lowering those goalposts, moving the goalposts, and in effect making more people ill, we have in fact said there are now 42 million additional Americans, if you set the level at 200, who technically have hypercholesterolemia and ought to be candidates for statins. And of course, when you think about the various drugs that lower cholesterol and what the cost of them has been until some of the generics came on board, you're talking about tens of billions of dollars for that one drug. Now the question, in Welch's book, he gives a number of other examples. So he talks about the blood pressure issue. He talks about the diabetes issue. He talks about the issue of, or maybe I ought to stop right there for a second. And so the question that I want to ask, and that I want you to think about now, is if we went back to one of the older levels, whatever that older level might be for blood pressure, diabetes, or for cholesterol, so that fewer patients would be on those drugs, would you consider that to be an example of non-rationing parsimonious care? And the basic problem is that if you ask why in the world were those cholesterol levels or hypertension levels and so on driven downwards, and in effect saying we ought to be putting patients on various drugs or doing other things to achieve those outcomes, the answer would be, well, you're going to have fewer heart attacks, fewer strokes, fewer vascular problems, and so on. And that's true. That statement is absolutely true. But the cost of buying those extra reductions in death or disability or the morbidity associated with stroke and heart attacks and so on, the cost of doing that gets extraordinarily high per event that is avoided as you drive those numbers down. And so the question we have to ask ourselves from a moral point of view is whether resources that are going to cost that much in order to prevent a stroke, prevent a heart attack, are resources that would be better deployed in meeting other health care needs that are equally important and that can be met at a much lower cost. Okay? So that's a question not just of economic efficiency, but it's a question of health care justice, which is why I talk about it. Efforts to control healthcare costs have resulted in a shift from a fee-for-service retrospective payment system to this prospective payment mechanism, which are more like budgets that hospitals and sometimes physicians have, if we're talking about capitated payments, and that are intended to maximize benefits for a group of patients as opposed to any individual patient that a physician might care for. The virtue of that approach to paying physicians and hospitals for the care that's provided is that it creates a certain amount of what you might call economic space and moral space to make trade-offs and to make judgments about where these resources are best allocated in order to maximize the good for patients. But that will mean that for any individual patient, they might be, from an objective point of view, less well off because of a trade-off that a physician might be motivated to make under one of these budgetary arrangements. There's this thing called the feudal care debate. A typical feudal care case is one in which a terminally ill patient is suffering horribly, family is demanding the physician all manner of life-prolonging care that's only going to prolong suffering and dying. The physician wants to withdraw aggressive life-sustaining care and provide palliative care and should do that. But the point I would want to make right now is that that choice is really not about parsimonious care or rationing. It's about doing the kindest thing possible to ease the dying of that patient. And we really shouldn't confuse those issues. The language, the political language, the rhetorical language of death panels and so on obscures what is in fact here, I think, an important kind of moral distinction. So how can physicians be loyal patient advocates and at the same time just prudent parsimonious stewards of social resources committed to not wasting limited resources for marginal and uncertain benefit for a patient? What has to be kept in mind is that it is social resources that are being entrusted to physicians. These are not resources that are your own resources. They are common resources either from an insurance company or from Medicare, Medicaid. There's a bunch of cases here that I want to give you just for sort of thinking about things and giving you some markers and reference points for judging some of these cases. First one, this was a case that got lots of attention back in the 1980s, the Wickline case in California. This was a woman who had, and now I'm not so sure of her age, maybe she was in her 50s, maybe 60s. She was on Medicaid. She had some serious vascular problems in her legs that were related to an abdominal obstruction. And she needed to undergo several surgeries in order to address these problems. Her physician, because she was paid for under Medicaid and it was a Medicaid DRG, the hospital administrator said to the physician, it's time for Mrs. Wickline to be discharged from the hospital, that she had overused her DRG days. And the physician said, oh, no, wait a second, can't do that. She needs 8 more days in the hospital. That's my best medical judgment. And the administrator said, no, she's out of here. You got it. And so they argued back and forth. Finally, they compromised, and the administrator said she can have 4 more days. So she got 4 more days, and then the physician discharged her from the hospital. Her leg became very infected after she was sent home. She ended up having to have one of her legs amputated, and she then sued the physician. She sued the hospital too, but the physician was the one who was held liable and was successfully sued because the argument was he had if he believed in his best medical judgment that she needed all 8 of those days, then he had to keep her in the hospital for those 8 days. The administrator of the hospital had no right and no authority to discharge a patient from the hospital. Only a physician could, and he discharged her, so he's the one who's held responsible for the damage that occurred to her, okay? So he would not have been, as the legal argument, at least the implication of the court opinion is, he was not as loyal, as persistent, and uncompromised a patient advocate as he should have been. Now, in contrast to that, we have the case of Hannah Kraus, a 92-year-old individual who has suffered a serious stroke, but she is still mentally competent. She has a whole bunch of medical problems, cardiac problems, and so on. And she is judged by her physician not to be a good candidate for bypass surgery. And from the point of view of her best interests. But she is demanding and demanding and demanding that she wants that bypass surgery because she's suffering angina and doesn't want to have to endure it any further. So we ask the question, is her physician morally obligated to provide that because she has made an autonomous choice to accept the risks of surgery, et cetera? Or could you argue that from the perspective of what parsimonious care is supposed to be all about, that there would be those would serve as one sort of reasons for not providing it, as well as the best interest of the patient. And then we'll skip over the Hunter syndrome. Well, no, wait. I should say a word about that. Hunter syndrome is a disorder that's going to be detected early on in life. It's a lysosomal storage disease issue. Up until within the past 5 years or so, there wasn't anything that could be done for this. These children typically died sometime during the second decade of life. The disorder would usually be diagnosed between ages 2 and 4, at which point there would have been some significant organ damage. Now, there's a drug called Elaprase that costs $300,000 per patient per year that can be given. It's an enzyme replacement therapy, and it works very well. The problem is that for Hunter syndrome, if it's the case that the disease has progressed so that there are now neurodegenerative effects of the disease, which can be measured over an 18-month period, then the Elaprase will do little good for that patient. That patient will still die during the second decade of life. On the other hand, if there have not been neurodegenerative effects of the disorder, then the patient can be given Elaprase at $300,000 per year for the indefinite future, and this will have significant beneficial effects for them. Now, the drug's only been around for about 5 years, so we don't know exactly how long that may prolong their life expectancy, but it's believed that because it will prevent organ damage and so on, that they may achieve several extra decades of life. A physician caring for these patients, should that physician be a strong advocate for Elaprase for the first set of Hunter syndrome patients who have some indication of neurodegenerative effects from the disorder, and say, well, I want them to have the drug anyway? Is a physician morally obligated to do that as a patient advocate? That's the question I want to bring up there. And then there's Mrs. Leone's left leg. This was a case that was actually sort of, in quotes, reported on the front page of the Chicago Tribune back in 1996, so that's why it caught my attention. Her leg was very badly shattered in an automobile accident. She was under an HMO contract. The surgeon caring for her had to get pre-authorization in order to do surgery. The surgeon asked the insurance, and speaking to a physician at the other end of the line, was asked, well, what's the most efficient thing you can do by way of addressing her leg? And the surgeon answered truthfully, says, well, you can amputate it for $8,000 and then fit her with a prosthetic device for $20,000. But then he quickly added, I believe I can save her leg. Now, it's going to be a really complicated surgery. The cost of doing this is going to be about $80,000, and I would guess there's a 70% chance this is going to work and that I can do this. The insurance company said, no, just amputate her leg and be done with it. But no, wait a second. They don't have. There's a happy ending here. Okay, so the surgeon said he ignored the insurance company and did the surgery and saved her leg. So he got a good outcome there. Now, there's a 70% chance. It could have gone downhill. If it went downhill, then you're going to have to amputate the leg, and then you're going to have also the cost of the prosthetic device and so on top of it. And so you ask, well, what's a reasonable response here? What is a morally appropriate response? Is this a situation where we applaud the physician for doing the really right thing, or was this physician arrogant in the mode of Dr. House on television or something? So that's how do we want to think about that particular case? Should we, when we ask where are we spending, it seems, excess health care dollars, one answer is going to be end-of-life care. And so 25% of Medicare dollars are in the last year of life and so on. There are prognostic devices like Apache 4, which is a very, very sophisticated instrument that measures a whole bunch of objective physiological variables on a patient when they enter an ICU, and then 24 hours later, and on the basis of what you learn there, the computer will crank out a prediction as to whether or not this patient's going to survive this hospital stay. If a patient has less than a 10% chance of surviving a hospital stay on the basis of Apache, should we agree that that would be a reasonable reference point for saying we're going to provide palliative care, we're going to pull back, we're not going to provide very aggressive life-sustaining care that will not alter the terminal outcome for this patient? Now this is a very complicated question, but it is one that we ought to begin probably to think about. The case of Nataline Sarkeesian, 17-year-old patient back in 2007, 17 years old, young girl, but she had leukemia. She had failed a bone marrow transplant. She was in liver failure, near death, and she was demanding, and her family was demanding for her a second liver transplant. The physicians, the surgeons believed there was virtually no chance that this was going to succeed. The HMO said, we're not going to pay for it, though because there was all kind of public pressure, they relented and they said, we'll pay for it, except Nataline died, as was predicted would happen because her medical problems are simply too far advanced and really beyond medical care. Were those physicians morally obligated as uncompromised advocates of Nataline's best interest to strongly advocate for the liver transplant because she and her family wanted it, and it might provide some extra months of life for her. We're not going to talk about Angel Diaz. We're not going to talk about Leslie Burke, but we are going to talk about a Mr. Krieger here. And Mr. Krieger, Mr. Krieger managed to rack up a hospital bill of $323,000 for a 10-day hospital stay. And he didn't want to do that, okay? Mr. Krieger was a man who sought to give to society, not to take. He was a successful engineer with an MBA, devoted husband and father, etc. He was 88 years old now. Alzheimer's had crippled his fine mind. His hearing had faded. Frustrated by his inability to hear, comprehend, or speak, he turned silent. There were moments of contentment, but every day he seemed more remote, sad, and uncomfortable. He asked for, and this is written from the point of view of his daughter, "My mom, dead for 5 years. He hid his wallet and accused caregivers of theft. One night he tried to escape from a nursing home through a window. His back ached, his heart was arrhythmic, and his bones had grown brittle. When he tripped and broke his hip 3 months later, surgery was traumatic. He couldn't understand why it hurt and where he was and why he couldn't sleep and so on. On the day before his admission to the hospital, he was shaking, dehydrated, and speaking gibberish. Fear was in his eyes. I raced him to Stanford's emergency room. The diagnosis was septicemia. And then after that, there's this medical cascade of interventions. The daughter asked this question, who was I to summon his death? Now, he had said he wanted to die a natural death. He had advanced directives in place. He'd also given his daughter to be in charge of his care. And he certainly didn't want to be resuscitated. But, of course, how precise were those directives in these circumstances and so on? Should a good doctor have resisted his daughter's request that everything possible be done to save his life, not knowing what would happen? Because there were extraordinarily expensive kinds of interventions and ICU care that were done that resulted in this $323,000 hospital bill. Is this a case where you would say, we certainly ought to be thinking about parsimonious care? And how would we bring that? How should a good doctor, a loyal patient advocate, bring that about in these circumstances? That's the question I'd ask you to think about. What gets us in the way of making what would seem to be more reasonable kinds of choices in the sort of circumstances faced by Mr. Krieger? These are the obstacles we're faced with. There's a vague belief human life is priceless, that we have a duty to rescue if we have the medical capacity to attempt to rescue, that we have to save identifiable lives. It's okay to have all kinds of abstract principles and rules about patients in general, but when you got the patient in front of you with a name and a face, you got to save them. You have to avoid being the cause of death due to denial of care, and you have to provide last chance therapies when there isn't anything else you can offer. What gets in the way of our making these judgments from a moral point of view, that is, from a perspective of a certain understanding of healthcare justice, is we don't really have a shared conception of justice. And so we have multiple understandings of what is just, and philosophers have talked about these, and each one of these that you have listed on the screen there are, in fact, reasonable, thoughtful ways of thinking about what would be a just outcome in a particular circumstance, but there are different conceptions of justice that are morally appropriate in different kinds of circumstances, and the trick is figuring out which one is the one that's most appropriate for the circumstances, say, that we're faced with regard to Mr. Krieger. So, in response to the bedside rationing, parsimonious care problem, some are going to argue that these sorts of decisions about what kind of parsimonious care is appropriate should be made at some higher level, at the CEO and so on, and that this shouldn't be the obligation of physicians. But the fact is that physicians are going to have to implement these decisions at the bedside which means that physicians have moral responsibility then for making morally defensible decisions about how those directives up here are going to be applied at the bedside. So physicians really can't avoid the kind of moral responsibility that I'm talking about here. In the case of some kind of top-down rationing protocols, physicians are still going to have to ask, will still have the moral obligation to ask what the source of the moral authority is for the rationing protocol, what assurances do they have that this protocol is just or just enough. Also, even if we assume that some protocol from on high is just enough, the question is going to still remain of how it applies to this particular patient. Now, in practice, no general rule can be specific enough to apply to the very complex circumstances, typically of individual patients, especially patients with lots of comorbidities and facing a possible terminal outcome. And this is true in clinical practice, I'm sure as all of you are familiar, as it is with regard to the moral issues we're talking about. So one alternative is you say, let physicians ration care. But then the issue is, would physicians be too disposed to favor their patients, especially a large accountable care organization, managed care plan, with consequent concerns about loss of both cost control and overall fairness? Or if physicians did make the necessary rationing decisions, would their personal biases against, for example, obese patients or patients with impaired cognitive capacities or with various kinds of psychiatric disorders, would that profoundly compromise what's supposed to be our commitment, our societal commitment to the justness of the healthcare system? And even if physicians were as unbiased as humanly possible, there's still going to be variability in clinical judgment in applying these protocols, especially from the perspective of patients who are denied some care they believe they would have gotten if they had a different physician. Physicians, as things are now in our current context, physicians can reasonably refuse to be rationing agents if they're expected to deny their patients necessary and potentially beneficial care when the savings that are achieved are going to flow out of the healthcare system and improve the golden parachute of some CEO or the bonuses that are given to various executives. So physicians should not and make rationing decisions or make parsimonious care decisions if they do not have some level of confidence that the money saved is going to be redeployed to meet what are higher priority, more just, unmet healthcare needs within that healthcare system. So what we need then is to create a leak-proof system for making these kinds of judgments, but we haven't created that. So would that solve the problem? Actually, no, because we have neither the social agreement or professional agreement about what those higher priority, more just healthcare needs ought to be, nor do we have the mechanisms for redirecting resources. We can argue that if physicians provide to insured patients everything that might offer some benefit in for their current medical problems, this is going to have cost escalation consequences that will get in the way of our being motivated to cover those who are currently without health insurance in the U.S. today. And that seems to be part of what's happening. The practical implication of that prior slide is that physicians have a serious moral obligation to be as parsimonious as possible in their use of medical resources so that we can include the currently uninsured. But then there is this potential tragedy of the commons problem. There is no overall coordinator of our healthcare system or of an individual managed care plan to make sure that all physicians are equally abstemious, and hence each physician will have a legitimate concern that their patients are going to be sacrificed at his or her hands without assurance that other patients are going to accept similar sacrifices, because it would only yield small benefits at a very high cost, $40,000. Then I ought to deny that to my future self as well if I were an Alzheimer's patient, an end-stage Alzheimer's patient in whom an arrhythmia had been detected. That's what public self-imposed rationing is all about. And then let's see, I want to go through some of these slides a bit more quickly because I do want to allow time for questions. But this ideal democratic process hasn't happened, and it's not likely to happen given the current political environment in the near-term future. So what should we do instead? And so what we can choose instead is prudent, evidence-fettered, shared decision-making. And two of my colleagues, Libby Bogdanovich and Margaret Holmes-Rovner, have proposed, quote, in equipoise situations, such an approach mandates a maneuver default to the effective and efficient option through directive counseling. And directive counseling would have to be done by the primary care physician. They then go on to write, in fact, the current emphasis on allowing the competent, informed patient to select medical interventions in an unfettered fashion imprudently reflects the present biomedical default option. If in doubt, do everything possible. That's what I referred to earlier as profligate or promiscuous care. In an era of expanding diagnostic and therapeutic technologies that add much in the way of cost but little in the way of measurable benefit, this consumerist cultural bias no longer serves us well, okay? Now, one of the other points that Welch makes in his book on Overdiagnosed is he calls attention to the exquisite, elegant sophistication of the imaging technologies that are available to physicians today. You can see, without invasive surgery, without harming patients in a substantial kind of way, you can see all kinds of detail within an individual's body that you'd never been able to see before. And as a consequence of that, you're going to see a lot of stuff that is abnormal. But then the question is, are all of those abnormal things going to result in serious disease that require some kind of immediate diagnostic follow-up, invasive surgery of some sort or other now, in order to head off that future possible 1 chance in 1,000 problem? And so, for example, just to give a personal example, I had to have an MRI scan about 4 years ago. And of course, they did a bit more of my body than they were actually wanted to look at. And they said, whoa, look at this. There's a little spot on your kidney there. I said, oh my God, cancer on my kidney. This is really bad news. And so fortunately, the physician explained to me, he said, look, at your age, everybody is going to have one of those spots on their kidneys. This is not anything to be concerned about. And that's what Gilbert Welch says as well. That you pick up all this kind of stuff. Now, is it at all possible? Is there a chance that that could become cancerous? Yes. Am I worried about it? No, because my doctor told me not to worry about it. Now, the question that Gilbert Welch asks, and that you sort of have to ask yourselves, he says, you know what? Radiologists would be doing a better job if when they spotted all these things, they just kept their mouths shut and they didn't write anything down because they, everybody's laughing there. This is a bad idea. and so, or the alternative is, he says, write them down, send it off to the cardiologist, the oncologist, primary care physician, but then suggest to them that they say nothing to the patient. Because if you say something to the patient and you let out a word like, well, of course there is this remote chance that that might turn into a cancer, that's going to elicit exactly the wrong response. And Welch has some really interesting stories to tell about that. And the most interesting stories are actually the stories of physicians as patients responding very badly to being told about these little spots and other abnormalities that were discovered in them. So he's not a strong supporter of doing things like whole body scans. This is a really bad idea. So my argument is physicians need to be intimately involved in the creation of these bedside rationing protocols for moral reasons and reasons of professional integrity. Physicians are most morally comfortable when these decisions are a product of their own clinical and moral judgment. They can be more comfortable with these guidelines if they feel they are evidence-based and a product of thoughtful assessment by expert medical professionals without conflicts of interest. So you saw in the prior presentation, that's one of the problems that we have, that oftentimes the medical experts who are best at formulating these guidelines are also tied up in various ways with drug companies and so on, and so there are conflicts of interest. Physicians are least comfortable to resource-constraining rules when they see them as a product of insurance companies just wanting to save money, or Medicare, Medicaid politicians wanting to tell their constituents we're saving money. If individual physicians insist that they have to have substantial control of bedside rationing, then how is it possible to preserve an adequate sense of justice across physicians within an institution or health plans? If they want to exert substantial moral and professional control, then they have to be prepared to invest substantial time and energy in creating these practices. So Hurst and Danis and Susan over here has been involved. She's worked with them as well, with Marion and Samina, offer the following justice-preserving practices. Identify in the medical record that a rationing decision has been made and the reasons in the mind of the clinician that would justify that decision, and then periodically review those. Identify ubiquitous examples of where clinical rationing is routinely accepted, and there are lots and lots of examples out there, but I can't give them to you right now. Physicians need to be educated regarding a range of reasonable conceptions of healthcare justice. We need to be respectful of individual patient clinical variation that may require adjustment, flexibility in applying these justice-based norms, and so we have to have that in mind. Reciprocity is a core element of our shared sense of justice, but it's misguided to ask, what will this patient gain now from sacrificing that is being denied some marginal benefit? The point is that that patient may have gained at an earlier point in time because other patients were willing to sacrifice the marginal benefit. So one of the things medicine has to do is to identify at earlier and middle stages of the disease process, cancer, heart disease, whatever, more effective, cost-effective ways of managing that problem, recognizing that when you get to the end stages of that disease, palliative care and other less costly ways of managing the end stages are going to have to be appropriate rather than these $50,000, $100,000 drugs. Respect for patients requires that bedside rationing decisions not be hidden, and that means you're going to have painful conversations with patients. So how do you justify bedside rationing? Effectiveness matters. The smaller the benefits, the less and the likelihood of effectiveness, the less of a claim a patient has those resources. Priority to the medically least well-off matters, but it must, the medically least well-off must in fact be able to benefit substantially from high-cost care, which is what was the point of the Elaprase-Hunter syndrome example that I gave earlier. Quality of life matters, and this does not necessarily speak against the interests of individuals with disabilities, because persons with disabilities will see themselves often as having very high quality of their lives, but it is a matter of there are certain kinds of functional states that are represent such a diminished quality of human life, such as end-stage Alzheimer's, persistent vegetative state, and so on, that those states should not command extensive resources. Cost relative to effectiveness matters. When a resource is absolutely scarce, two individuals are competing, allocate in a way to yield the smallest degree of injustice. And let's see, degree of money sometimes matters, but so individuals who are wealthy, they can buy out of their own pocket expensive, minimally beneficial health care. That's okay, as long as it doesn't adversely affect the rights, interests, the just claims of others. Age by itself is rarely sufficient to justify bedside rationing decisions, though there are going to be a range of circumstances in which this is a morally a consideration that ought to be taken into account to some degree. Efforts to avoid bedside rationing by appeal to deep personal values will generally not be justified, especially when it's social resources that are being extravagantly allocated. And a seventh competency for medical students and residents, they should be trained to understand the need for stewardship of resources and practice cost-conscious care. Now it's time to think, and that means all of us. Those are two little grandkids. Yeah.